Hello, everybody. Welcome to the Pan American Trauma Society webinar. This is going to be section number 3, the webinar number 3. This meeting is sponsored by the Pan American Trauma Society in association with the American Association of Surgery of Trauma, PST International Relations Committee, the World Coalition for Trauma Care by the University of Miami, and the Virginia Commonwealth University, VCU. We also have all the other societies that are part of this network joining us, and the names of the societies are in the screen right now. And please, Valeria, put the slides big. And I would like to invite my friend, Dr. Michael Abutanos from VCU to introduce the international panelists, please.
Thank you, Dr. Martos. So again, it's a pleasure for us to have everybody on. I'll quickly mention our panelists, and then Dr. Martos will mention our main speakers. So our panelists, again, we have Dr. Thomas Scalea, Executive Director of the Pan American Trauma Society, and the Honorable Francis X. Kelly, Distinguished Professor in Trauma Surgery, Professor-in-Chief at the R. Adam Cowley Trauma Center, and System Chief for Critical Care at Critical Care Services, at University of Maryland Medical System. So we're hoping that Scalea will be able to join us. He may be a little bit late, he stated. Dr. Raul Coimbra, as you all know, founder and executive director of the World Coalition for Trauma Care, surgeon-in-chief at the Riverside University Health System Medical Center, and professor of surgery at the Loma Linda University School of Medicine. We'll also have again today Professor Bofart from South Africa, who is the trauma director and academic head of the Mill Park Hospital Academic Trauma Center, and professor emeritus in the Department of Surgery at the University of the Witwatersrand. And we have again Dr. Mauro Zago, who is the director of General and Emergency Surgery Division of the Robotic and Emergency Surgery Department in Manzoni Hospital in Italy. And we also have this time from Iran, hoping we'll be able to join us, Dr. Ali Jafarian, who's the founding chief of the Division of Hepato Pancreatic Biliary and Liver Transplantation in Tehran, in Iran. He's also professor of the Department of the General Surgery in the School of Medicine at the Tehran University of Medical Sciences. And we're also hoping that Dr. Napolitano from Michigan in the U.S. will be able to join us, depending on how busy she is, and who is the director of the Surgical Critical Care at the Massey Foundation, where she's a professor of surgery in the Division of Acute Care Surgery and Trauma. And she's also the associate director of the Michigan Center for Integrative Research and Critical Care at the University of Michigan Health System. So those are our 6 panelists for today.
Thank you very much, Dr. Abutanos. So, Valeria, go back to the first slide, please. So the idea, just a disclosure, this meeting is being recorded, so everybody participating agrees to have your image, your voice, or audio questions being recorded, and the link of this meeting going to be the multiple worldwide medical societies. Also, this link can be watched. This meeting can be followed by media, press. So anybody that you talk here can be public. So be sure that you only make comments that can be public, please. Okay. So I would like to introduce the first presenter. He's a great friend, Dr. Hayato Kunihara. He's a professor at the University of Milano and Humanitas Hospital in Milan, Italy. Dr. Kunihara made the first presentation to us at the University of Miami 4 weeks ago, and has been giving us up to date on the situation every week. And he's going to be followed by Dr. Alessandro Proti, intensivist at the Humanitas Hospital, University of Milano also. You're going to have 2 good presentations, and then following that, you're going to have a great discussion, time for discussion, okay? Dr. Hayato, it's our pleasure, honor to have you back here with us. Please share your knowledge, your information with the globe. Thank you.
Thank you. Thank you. You hear me? Yeah.
Yes, very well.
Thank you. Thank you very much. It's going to be just a brief update since in the past 2 weeks, 3 weeks, I was going to update you about regarding our situation. It seems that we are just starting now to see some light at the end of the tunnel. This is the progression of COVID-19 new cases. You see, 3 weeks ago, we had just 9,200 patients that were positive. 2 weeks ago, 35,000. Last week, 63. And now it's more than 100,000 patients. But it seems that, really seems, we will see really in few days, it seems that we are reaching the peak, because for the very first time, now the number of people that are discharged from the hospital and people that is admitted is going to balance for the very first time. So this is the situation by now. This is the cases by day. And as you can see, this graph is from the World Health Organization. It seems that we are really starting to have probably the first results, at least in Lombardy, of the national lockdown that started a few weeks ago. So in these past weeks, the numbers of ICU beds all around the country has been increasing and increasing and increasing with a quite surprising progression. And just to give you an idea that in less than 1 month, all over the country, we could set up 90,000 ICU beds with an exceeding number of 75%. And we had to create many medical ward beds, mainly as pneumologists, medical ward in general, and infectious disease beds that has been reaching more than 400 times the usual numbers of medical beds for minor patients. We have been running constantly with 100% saturation of ICU beds. The ICU surge capacity before the crisis was in Lombardy. That's our regions, about 460 beds. Nowadays, we had around about more than 1,300 beds. But for the very first time, we did not have a progression of the use of ICU beds. And in the past weeks, we could create more than 800 beds of ICU. I'm sure that Professor Crotti might have more detailed data about that. So things are really a little bit improving. And this is our new hope. This is the Fair of Milan. And that was just finished yesterday. We had this new big hospital that has been set up in the past 10 months. Now the first that was opened just it's going to open today, I think. So I do not have data regarding that. So the first 53 ICU bed has been created, and the surge capacity will be of 200 beds, and that was possible through donations mainly from private, individual, and company donation. There has been a huge commitment all over the country with Ferrari that was building valves for ventilators, Bulgaria that was delivering the antiseptic solution for hand scrub. Armani was dealing with the lab coat, disposable lab coat, and so on. And in Bergamo, that's the other area that has been really hardly hit by the coronavirus. This field hospital has been built with the help of the Alpini, that they are veterans from our army, and we had a lot of volunteer people that has been building the hospital in less than a week, I think in 6 or 7 days. You can see the enthusiasm of the people, they all volunteer that started to work here. The beginning, the request was of 12 voluntary carpenters. We had 250 carpenters that on voluntarily basis start to work and build the hospital. So as you can see, the median age of cases is 62 years. This is the update of yesterday. We had almost 10,000 healthcare workers that got infected. So as you can see at the national level, we had a problem with the personal protection probably. But the most of the cases are not that severe. But still, we have quite a lot of critical care patients, and this is the mortality of our population. As you can see, what is really concerning is this age, between 50 and 59 years old. The mortality is 2.1, and I think this is usually part of the population that usually speak, and the mortality rate it's quite high. But anyway, things are improving. This is Milan, same picture I showed you last week, and I hope that in a few time we will have an improvement. So it's just a short update on what is going on.
Thank you very much, Dr. Hayato Kunihara. So now, Dr. Proti, you are very happy to have you here today. We know that has been a lot of work for you. We have been working non-stop. And thank you for accepting our invitation to share your lessons learned, your knowledge, your expertise in the management of the critical patients with COVID-19. So ready to listen to your presentation and then to make a lot of questions for you, okay? Thank you very much. Again, I really appreciate joining this conference.
Thanks for this kind invitation, and it's a privilege for me to be here. I'm looking at myself in the screen and I realize I definitely need an haircut, but right now it's no longer possible in Milan to have an haircut. Everything is shut down. My presentation is quite similar to the one that Hayato gave, at least in the first part. So maybe we can start with it, and then I will jump to the part referred to critical care rather than epidemiology. Okay. And I'll be happy to answer to as many questions as I can. As this is a very new disease, I'll do my best, but I do not have any evidence-based answer. It's just experience, initial experience. So, I think I have to go here. I would like to go to the next. Okay, so this is, we already spoke about this. So luckily enough, in a way, the problem started in the richest area in Italy, with approximately 1/4 of the ICU beds in Italy. My numbers are slightly different from those that Hayato reported. They include also ICU beds in private hospitals that work with a national health system. So we started with 700 beds, and in order to, yes, I'm okay. These are the total numbers, approximately 100,000 cases. Luckily enough, 60% of them do not require a hospital admission. but 40% do. And in just 1 month, we had 4,000 people in Italy requiring ICU admission. 4,000 people, 5%. Yes. So, how did we react? The first case in Milan, south of Milan, occurred 45 days ago. And after 3 days, we were able to create a network that connected 55 of the 74 hospitals in the region. And this network is coordinated by a hospital that is located in the center of Milan. And initially the network was based on the network that was already established for using ECMO for acute respiratory failure, the network that is called Respira, that is coordinated by Professor Pesenti and Professor Zangrillo. And then the network was expanded so that now it includes 55 hospitals. And people admitted to these hospitals, to the ICUs of these hospitals, approximately 1,500, the beds. The total admission is about 3,000. And it's true that nowadays ICU admissions are declining, but one important point is there are no longer available ICU beds. So it might be that there's no more people needing ICU admission, but for sure, there are some of them that are waiting for a free bed. So that's why a new area was created, the one that we saw in a previous presentation, although that is not already yet working. And as for now, hospital mortality in our region, ICU mortality in our region is approximately 60%, just considering the cases that were discharged. Okay, can we go to the next? Thanks. So this is my hospital. So it's a private hospital that is linked to the national health system. It's mainly a surgical hospital. It has 15 beds for general intensive care, 9 beds for post-cardiac surgery, so 24 in total. And I would say that 7 to 8 beds are normally dedicated to the emergency department, whereas the others are dedicated to post-surgical admissions. Whereas nowadays we do have 65 beds, 55 beds. 40 are dedicated to the COVID area, whereas 15 beds are now dedicated mainly to cerebrovascular accidents. So as for the non-COVID patients, the region decided to dispatch different patients to different hospitals. So we no longer should receive myocardial infarctions or big trauma or traumatic brain injuries or other kinds of emergencies. We should only receive ischemic stroke or eventually hemorrhagic stroke, and then just COVID patients. And we were able to increase our ICU surge capacity by creating a very large ICU within the operating theaters that are virtually closed, shut down. There's only 10% of the normal activity is still ongoing, and that's oncological surgery that cannot be deferred. Yes, can I skip to the next? This is our, we received 80 approximate, can you go back just one, please? So we treated 43 patients And that's our, right now we have discharged 46 of them. As you can see, 60% are the survivors and 40% are the non-survivors. The good point is that those who managed to survive until the ICU discharge, they all went or are going home. So if you recover, you recover for good. And that's a good point. The mean age of the survivors is 61. The mean age of the non-survivors is 69. The mean length of stay for survivors is 7 days. The mean length of stay for non-survivors is, I think, 10 or 11 days. Yep. So this is a very brief presentation of our patients at admission. So even if we are part of a regional network, most of our admissions come from our own hospital. We are located very close to the site where the initial outbreak started. And so we had a lot of admission from our own emergency department, and just 16 patients that arrived or were referred from other hospitals that did not have any ICU beds. And as you can see, it's just a brief presentation, but the main problem is hypoxemia. So that's the ratio between arterial oxygenation and the fraction of inspiratory oxygen. And it's moderate to severe ARDS, or maybe moderate to severe bilateral pneumonia. We can talk about that. And most of the time, the organ failure is just lung organ failure, so one organ failing, whereas as you can see, the kidney, the liver, the platelets are working, are not failing or dysfunctioning. And the vasopressin need is mainly related to sedation and high PEEP, but they do not usually have a proper cardiovascular failure or dysfunction, a proper shock. Okay, and this is how we tend to treat them, or possibly how we would like to treat them. So it's mainly organ support, and I don't know if it's etiological support therapy. So we use antiretroviral drugs, anti-malarial drug, antibiotics for community-acquired pneumonia. We tend to use antibiotics as well, although co-infection is not common. And then we do use, I know there's a lot of rumor about how to use heparin in these patients, and we simply use full prophylaxis, but do not anticoagulate these patients. So this is the end of this very brief presentation, and I'll be happy to address all of your questions and needs.
Thank you, Dr. Proti. Now is the interesting time of the talk or the webinar. So I will start with some questions, then I'm going to ask Dr. Michael Butanos to rotate through the panelists. So we have been seeing that the mortality in Italy is very high compared to other places in the globe. Some people are saying maybe because, again, the surgery was too fast, so and there are too many patients at the same time. And other people are saying, well, maybe because the population is elderly, the age is more elevated than some other places in the globe. And what did you learn since the start? So did you see after you start to use the antiviral therapy, the hydroxychloroquine, the anti-malaria therapy, so that you can see a difference when you start to use these new treatments from the beginning? So what did you learn since the beginning from the last month, and how you manage this patient change it, and how did you see, how did you came to this standardized protocol to treat your patients for now? So please tell me a little bit of history. So what kind of patient, this patient going to do well, this patient not going to do well, and what can you teach or what can you advise the rest of the world how to manage these ICU patients with your expertise?
Okay, so I do not have a standard protocol right now. The protocol changes day by day in a way. We are really in a phase of try and learn. So it's mainly looking at these patients and try to learn from them. So the main things I've learned and changed in the way we manage these patients is how we use PEEP and how we use prone positioning. So we started, my background is mainly related to how to treat ARDS. My mentor was Professor Gattinoni. I worked with him for 20 years. And these patients are very hypoxemic. And so we started treating them with very high PEEP, and we tended to prone most of them. We encountered two problems with this, or possibly three. So the population is very heterogeneous. So some patients definitely come to the ICU with a bilateral pneumonia, whereas some others come with ARDS. That's possibly related to the time that the patients spend at home, in a way fighting with the virus, and with a course in hospital. So how many days the patient spent on CPAP, on non-invasive ventilation. So, so that when they arrive to the ICU, their pattern, their CT, the lung computed tomography, lung mechanics can be very different. And very high PEEP is rarely needed. I think we should tolerate a little bit of hypoxemia. We started tolerating a high FiO2 because very high PEEP is usually associated with a big problem with kidneys, and we can't afford renal replacement therapy for everybody. As for prone positioning, my personal opinion is not very useful. I know my mentor will hate me for this statement. And it's not very useful in terms of, it works to relieve hypoxemia. So I do consider it when a patient is very, very hypoxemic. But otherwise, it's pure cosmesis. When you turn the patient supine, the patient most of the time will look exactly the same as the day before, unless the CT is highly suggestive for a gravity-dependent edema distribution, but that's not the rule. So less prone positioning and a PEEP that is not higher than 15, as we previously did. Sorry, one last point is that as time passed, we had to ask people who are not expert in intensive care to join our team. So prone positioning is becoming a very challenging maneuver. It's no longer a routine practice. I'm definitely sure that accidental extubation will happen one time or the other, because people are no longer expert with that. And so we tend to avoid prone positioning unless it's strictly necessary.
Dr. Prodi, thanks for your comments. This point is very important. And actually, Michael Butanos, I mean, we were talking about this yesterday. Some hospitals in the United States, they do proning, some others, they're not used to that. So need to teach, train the nurse and the physician to do that. And you know, the people can get extubate, have vasovagal, et cetera, et cetera. And I don't know, Dr. Loeb is here, he's our, and Dr. Godzak, they run the ECMO program at university. And I know they do a lot of ECMOs. In your institution didn't do a lot of ECMO. But I want to Dr. Michael Butano. Dr. Butano, and I know that Dr. Paula Ferrara has some comments regarding this matter also. Can you make your comments about this, Dr. Butano, and check the questions for the other people? Please, everybody, put your questions on the Q&A box. Don't make a question on the chat. There's a link that you can click, call in the bottom or the top of the screen called Q&A. Please click there to make your questions so we can make this question for the presenters. Thank you.
Great. Thank you. Actually, I was very happy to hear Dr. Pari address the proning. This is debated in many of the trauma centers that we have. Obviously, in places that have experience with proning, it is part of their routine management for ARDS. But for other hospitals that don't usually prone, now they're considering it. And so it's and we all know, and at least in the regular disaster management, you don't invent a new thing. So this kind of being debated in many places. So did you have a special team that did the proning in the hospital that have experts, or you just had anybody who's managing the patient should be able to know how to do it? And how much of a nursing experience was needed for this? This is for Dr. Pari to answer.
Yes, I'm here. Nice to hear you. So when the emergency started, we had some training at the simulation center where we train our nurses and doctors how to prone a patient just with 3 people. So 1 medical doctor and 2 nurses. Whereas we usually do it, that's a routinary procedure in our hospital, in our intensive care. But we usually do it in 4 or 5 people. So doing it in 3 people is not that tough, but the point is that, and again, prone positioning is common practice in my hospital. The point is that if you go from having 15 beds to 55 beds, you will have to ask nurses that usually work in day surgery to come to the unit to help you during the night shift, for example, or to ask the anesthesiologist who works in orthopedics, have worked in orthopedics for the last 10 years, to be on call during the night. So these people are not used to prone positioning. And as you said, you can ask people to get familiar with something they are not familiar with during an emergency. So my suggestion is do what you are familiar with and nothing more. So if you're not familiar with prone positioning, leave the patient supine and work with the FiO2. That will definitely be much better. But even if you are confident with prone positioning, I'm not sure it works as it usually works in other ARDS cases.
Great, thank you. I think Dr. Bofar, you have some additional questions yourself.
Yes, sir, you're muted, Dr. Bofar.
I'm now unmuted. I had 2 questions. We've got at this stage a very, very early entry. For whatever reason, we were able to lock down within about 15 days of our first case, and in fact locked down before the first death occurred. Our policy with ARDS, particularly in trauma, has been using prone ventilation later, recruiting very early, and ECMO a very low threshold for using ECMO. So I would be interested in Dr. Pozzi's views on the timing of those 3. Thank you.
So very interesting. This is a very strange population. So if you look at their CT scan, approximately half of them do not have a large amount of non-aerated tissue that can be recruited. It's not because that's consolidated, but simply because there's no non-aerated tissue. It's an interstitial bilateral pneumonia, but it does not look as the heavy sponge of the ARDS baby lung. So I'm very aggressive with all the measures that are meant to recruit the lung, high PEEP and prone positioning. But I'm not sure this is the most appropriate approach in this specific syndrome, or at least in quite a large fraction of the patient with this COVID-19. As for the ECMO, this is my personal opinion, and it's based on the context where I work. I think that running ECMO now in Italy, in Milan, is not ethical. So we are running out of propofol. We do not have more, we have no more levofloxacin. We have no more personal protective equipment. We have not enough ICU beds. So ECMO is too resource consuming, and I can't run veno-venous ECMO with nurses that were working in day surgery until 3 days ago. So that's too dangerous. So unluckily, I won't be able to offer ECMO to patients that eventually could have been treated with ECMO 3 months ago for a different disease. In a different scenario.
So Dr. Prodi, you are saying that there's a role for ECMO in this situation, but since you are in a mass casualty mode, it's not just not feasible at this moment. But if you are in a center that your capacity is not above you're not above your capacity, and you have the team, you have the resource, it could be an option, but it's not an option in Italy right now because you are in mass casualty mode, correct?
So it's correct. I think that the way the health system works in Italy make a huge difference. So in Italy, it's a national health system. So even if my hospital has the chance and the bed to do ECMO, by doing it, I'm wasting money for the other hospitals in Italy. So we have to think on a national basis because we are all consuming resources on a regional or national basis. So I think that running ECMO in Italy is not appropriate at the moment. I know that in the States, the system is quite different, but for sure, some patients die from hypoxemia, and veno-venous ECMO can be life-saving during hypoxemia. Agree.
Dr. Prodi, thank you. Another quick question. Many of the questions and answers are asking about the use of steroids in the patient. Do you use them, and if so, when, and at high amount, low amount, etc.?
So we don't use them, never. So first of all, this is our decision. I can't say it's the appropriate protocol. We are very scared of the side effects of steroids during a viral infection. However, I think we are patients that do not start to recover by day 7 or 10, possibly develop pulmonary fibrosis by day 15. I'm saying possibly because their lung compliance becomes very low, so very stiff lungs, and respiratory acidosis, that is not a problem at all at the beginning of the story, becomes a problem at the end, after 2 weeks. That might be pulmonary fibrosis. We're not allowed to do autopsy if a patient died. So I can't be certain that's fibrosis. We are doing some imaging on the late phase of the disease. And one protocol we may consider is by day 7 to check for if the COVID-19 is negative and if the procalcitonin is stably low. So in a way to exclude an active viral infection and a bacterial co-infection, we will possibly consider starting with some steroids, but it could be, for example, we call it the Meduri 2 protocol, so methyl 2 milligram per kilogram per day, but it's just an idea. We've never used them right now, so far, sorry.
Great, thank you. We have more questions and answers, specifically with the use of non-conventional ventilation. We have similar questions came from Dr. Gustavo Norte and Dr. Farada. Also with regard to the use of pulmonary echography. Do you use ultrasound, and in your evaluation of the patient, how do you use it?
Okay, so no conventional ventilation, not at all. Again, do what you are familiar with. So right now is volume control, very easy, very simple, nothing special. It is probably suboptimal, or it is possibly suboptimal, but we are trying to deliver decent care to everybody. This is our policy at the moment. And we try to, our priority is, in a way, do no harm, do no mistakes. As for lung ultrasound, in intensive care, we do not use it a lot. Luckily enough, we do have a dedicated CT scan just for COVID patients. So it's very, very easy to get a CT scan. At least at the beginning, the CT scan is taken, and as it's even more sensitive than the microbiological testing for the diagnosis. If the CT scan suggests COVID, then we strongly consider it COVID, even if the swab is negative, or even if we can't find COVID on the aspirate or on broncholavage. But I know that ultrasound is used quite a lot outside of intensive care by pneumologists and emergency physicians.
Dr. Prodi, there's a couple of questions here regarding aerosolization, aerosols. So Dr. Rodas and Dr. Luciano Eifer from Brazil, and they ask about, okay, what indication for tracheostomy? You know, multiple ICUs around the globe say, okay, you do early tracheostomy day 7, between day 7 and day 12. What's your indication for tracheostomy with the risk of aerosols, airborne, et cetera, and to, are you doing that to just avoid the risk to contamination, infecting the medical team, the healthcare staff? What about laparoscopy? So what can you tell us about doing chest tubes, intubation, and even when you have a cold? So do you just keep the patient at the ventilator, use the ambu bag, or do you just contaminating everybody? Just some comments about this kind of risk and how do you manage that in your protocols, please?
So our personal protective equipment is very, very high standard, possibly too high. It's taken from the Ebola guidelines. We feel quite confident for a procedure like intubation or ventilation or To be honest, we would feel confident with tracheostomy as well, but so far 80 patients would never perform a tracheostomy. If a patient does not start to recover by day 15, day 18, the patient usually has developed kidney failure by that time, sometimes liver dysfunction. And I don't think that we can, in this situation, I don't think we can think of a chronic critically ill patient, especially because out of the ICU is a mess. So the system won't be able to take care of a patient that has myopathy, that is very susceptible to infections, that needs some help with a kidney dysfunction, not at this time. So we tend to offer a chance to everybody, and we've managed to offer a chance to everybody, but the patient, we expect some positive response to therapy within 2 weeks. And we tend to manage the patient with a tube. And if so it's not early tracheostomy. I can understand that early tracheostomy could be a different scenario, but tracheostomy by day 15, you usually can't wean these patients because their lungs have become too stiff. So I'm not sure that tracheostomy would solve the problem.
So this patient probably see on a high PEEP, etc., right? So you can just not see an indication. So how long does usually the patient that takes to recover? How long are they intubated, and how long did the patient become intubated before they die? So they die quickly, or they die over some weeks? How is the pattern of the survivors and the non-survivors?
So the COVID-19 has quite a long course, and it's hard to say how long it lasts because most of the patients arrive to the hospital after several days complaining symptoms. If they are old, they arrived after 7 to 10 days with fever and dyspnea. If they are young, they arrived after 20 days with fever and dyspnea. And I think that the first 4 to 5 days, you just need to put them on a mechanical ventilator in their bed, start with therapies. I'm not 100% sure whether they are effective or not, but you should forget about them. Leave them, don't interfere with nature, and allow them to rest, and don't expect any improvement in the first 4 to 5 days. And then those who recover usually are discharged by day 10 or 12. So after 5 to 6 days, you can try and eventually start the weaning process. Whereas those that are eventually die remain stuck on a very high PEEP, on a high PEEP, no longer a very high, but high PEEP, very hypoxemic. The lungs start to become stiff. They possibly develop fibrosis, possibly. The problem is that fever lasts weeks. Yes, PCT, procalcitonin is usually low at the beginning, but then start to move. And we've not felt confident so far to use steroids, but we may consider it. The longest course we had was something like 24 days, but we tend to discuss every single case after 14 days.
So my last question. Yeah.
Sorry, Dr. Coimbra had a question about innovative ways to decrease the use of PPEs in the ICU? What have you done to do that? Any creative ideas?
I'm sorry, to decrease the use of personal protective
Personal
equipment.
protective equipment. That's right.
Okay. Now, so right now we've been able to afford personal protective equipment of high quality. So time to time we had problems in getting the FFP3 mask. I perfectly know the FFP2 or N95, maybe you call it N99. We started with the N99, and time to time we had to move to the N95 because of shortage of the N99. But I personally believe, but all the guidelines suggest that N95 is adequate as well. We use all gloves, and we've been able to have those as well. So right now, it is mainly, we can afford personal protective equipment for the staff, but not for other people that is willing, for example, to do research. There's quite a marked restriction in the access consume personal protective equipment. But we didn't have to change our practice at the moment.
Go ahead,
just have here Dr. Horowitz from New York joining. He's in the middle of like a huge surge in New York also. So I don't know, Dr. Coimbra, is he as a panelist? He's supposed to have access to camera. I don't know what happened. So Dr. Proti, are you, when the patient has cardiac arrest, are you resuscitating or just when they arrest, they arrest? At some point in 14 days, do we withdraw care of these patients or just let them go to natural death? So how you manage this cardiac arrest and when do you stop?
If it's cardiac arrest, it's too sick to be treated in a situation like this one. So I think that you can't really understand the situation until you are in the situation. And our hospital has managed to give an ICU bed to all the patients that arrive, but it's a large university center. But there are other hospitals where people are managed with with ambu, manual ventilation in an ordinary bed, waiting for an ICU bed. So if you need to have a triage system, and if a patient is so sick that suffer from a cardiac arrest, the patient is too sick to be treated. This again is my personal opinion and our protocol. I'm not saying that everybody should do that. It depends on the, I think, on the local context as well.
Okay. I think Dr. Horowitz from New York is just joining us. Dr. Horowitz, can you tell us your experience in New York and what kind of protocol treatment is working, please? Yeah.
I actually brought Dr. Zach Kahn, who's one of our 2 ECMO surgeons, who has cannulated basically all of our cases to give you his perspective.
Yeah, so I will echo what was just said. I think ECPR in this context is not a sensible use of resources. I think these folks tend to be a different flavor of ARDS than what we're used to. That being said, we've taken a very, I won't say aggressive because it's selectively aggressive approach with who we've cannulated. So young, healthy, no comorbidities, we've basically put them on, and I think it's a little bit more of a protracted course than some etiologies of ARDS. So usually, they're on and off in a week, 10 days. These folks seem to be closer to 14 or 21 days. And the early couple days seem to always kind of get worse. Now, I think there's been 2 kind of phenotypes that are distinctly different than typical ARDS, where it just whites out. It's a completely restrictive lung disease with just poor oxygenation, poor ventilation. Here, some folks will have that, but a large majority of folks will have this other strange phenotype where their compliance is okay and they're almost a true obstructive lung disease with just tons and tons of dead space and unable to clear CO2 despite, you know, tidal volumes of 500 without incredibly high peak airway pressures. I think those folks obviously do a little bit better, but you know, we've now put on 11 folks. We just took off one today. We're probably going to take 2 off tomorrow, but all 3 of those were on for about 14 days. So I think we probably would expect a lot of them to be along that course. The other folks that are on now are all in the 7 to 10 day range, and I think they probably need another week or so before it's going to be realistic to take them off. We have been very, very, very aggressive with tracheostomies in these folks. I think it's made airway management much, much easier. I think there was a lot of concern at first in regards to staph exposure, but the reality is, one, if they're on a closed circuit, they're still on a closed circuit, whether it's a trach or an ET tube. And the second is, you know, the reality is we put these patients on high flow nasal cannula before they get intubated, and we aerosolize the whole room, and we kind of say that's okay. But suddenly, you know, they're at their convalescence, hopefully, of their disease and maybe on trach collar, and now we're suddenly concerned that they're going to expose the staph. So we've been very aggressive, and I think that's made a huge difference in airway secretion. We've bronched, I'd say, most of the patients on a daily basis for the first couple of days, just because they've had such tenacious secretions. And I think that has helped kind of recover quite a bit as well.
And the first ECMO patient that you trached was out of bed to chair the next day.
That's true, yeah. He did particularly well. He was that other phenotype I kind of was alluding to. He was hypoxic. He was on 100% FiO2 when we put him on, but that wasn't his real issue. Was this kind of dead space ventilation where his CO2 was skyrocketing despite, you know, not horrendous ventilatory settings, but actually quite good tidal volumes and minute ventilation. We just couldn't drive down his CO2. So, you know, I think those folks will tend to, you know, be in a chair more than some of the other folks, but at the same time, I think that's some of the benefit as well. Lightening sedation, not having them paralyzed, all the, you know, I don't know that any of these folks are going to be ambulating, be quite honest, that, you know, maybe we had one guy that maybe could if obviously there wasn't an in-room restriction. But I think from all the other aspects of pharmacologic sedation and paralytics and things like that, it's been very helpful to wean on these folks.
Okay, I'm going to extend this conference for 15 more minutes. Dr. Butanos and the other panelists, more questions. I know Dr. Raul Coimbra is here. Dr. Raul Coimbra, any questions or comments for the panelists, please?
Antonio.
Yeah, Dr. Prati.
I have to leave. I'm sorry. Can you hear you?
You're muted, Dr. Marcos.
Yes, we could hear you.
Thank you very much. Thank you very much for joining us. I'm going to continue a little bit more with the panelists.
Okay.
It's a pleasure to have you. Thank you very much.
Bye, guys.
You're doing a great job. Thank you.
It was a privilege for me to join your talk. Thanks a lot. Bye. Ciao.
Dr. Coimbra, your comments, please. Your questions.
Antonio, thank you so much for putting this together again. Wonderful webinar. I think that the question I asked about creative ideas to decrease the use of PPE in the ICU is one that I would like broader discussion. You know, there are ways to decrease the use of N95s. There are ways to protect people when intubating. There are ways to bring equipment from inside the room to outside of the room, like infusion pumps, and manage them from outside the room with long tubing. And yesterday, I was surprised when I saw in some of my chat groups that some folks are taking X-rays from through the glass door in the ICU to avoid the tech going into the room and having to use PPEs and etc. And obviously X-ray is a form of light that goes through glass. So I'm wondering if people all over the world in this webinar are using some of those measures to decrease the unnecessary use of N95s, which we all ran out in about a week to 10 days because the supply chain, unfortunately, in the United States is not there. And it seems that the help from the federal government is not coming soon.
Dr. Hayato first, then Dr. Horowitz.
Hi. So we put all of our IVs in the hallway, and then in some of the floors we've taken the monitor off the top of the vent. We have servo U's, and you can unhook the monitor in a servo U or servo I, and it has an 8-foot cord built in. And so we've strapped that to some chairs in the hallway. But the pump change has been a big help.
Yeah, that's a question that should be addressed to other hospital in Italy. I mean, with public hospital, we live a very lucky positions in my hospital. We never went, almost never went out of stock. So because the supply chains really have been doing a great job. We have to count every PPE at any shift, but we didn't have any problem.
Can I add one point? And this is going to be, I think, a little taboo. It's Zachary Khan from NYU again. You know, I think we have to be very careful, and I am not belittling the absolute appropriate concern of exposing staff and physicians and nurses and X-ray techs. It's absolutely a critical thing that we do adhere to PPE and do take care of these patients appropriately, ourselves appropriately rather. But I think we have to be very careful that it's not at the expense of patients, you know, that we actually are appropriately weighing that risk to ourselves versus the lack of care for the patients. And I think early on, that was one of the things we really, and please don't quote me on this, I know we're being recorded, but struggled with is just pulmonary toilet. People were too afraid to go into the room and suction an ET tube, and that translates into a bunch of patients having occluded ET tubes that emergently need to be changed out. You know, people not being willing to bronch any patient ever for any indication, and that translates into people having all these post-obstructive pneumonias. So while it is absolutely critical that we protect ourselves, our staff, our families when we go home, you know, at the same time, we really do have to think critically. Are we emphasizing too much our own safety versus the actual care we need to give to the patients? And I agree with you. It's going to be a hospital by hospital, you know, physician by physician question. But we do need to start thinking not being in the room ever for a patient, I think is not the right answer. And I think actually those patients are the ones who do the worst, is the ones that we're most careful about, you know, having everything outside the room that no one ever walks into it.
Well, that was not what I suggested, obviously, but when you lose 10 or 15% of your workforce, you know, you're not going to have them there anyway. So I think we need to put this in perspective to make sure that at the same time that we provide the highest level of care that we can, we still protect those that are in the front lines to make sure that they are coming back to work the next day.
Absolutely, 100%. I didn't mean to imply you were saying anything else. My point more is I think the IV poles in the hallway is a great idea. I think having the ventilator, you know, monitor put on a chair outside the room is also a great idea, right? There's no reason for those things to be in the room if they don't have to be, and those aren't things that help the patient in any way by being in the room, right? I think my point more was, you know, the next step on those things, you know, never going into the room for things that do help patients. And that was my only point, to make sure it doesn't slide into that, which it has in many centers, I think.
So we developed CPAP masks with bidirectional filters for all critical care physicians and frontline doctors in the ER and surgeons in the COVID OR to avoid using, you know, 80, 90, 100, 200 N95 masks, and you change the filter once a day. So we are there to provide care, but I was interested in, you know, all the ideas that people are having to avoid unnecessary in and out of the room. And every time you go in and out of the room, you throw a mask in the trash can because then you need to go to the next room. And I think that there are some options out there to avoid unnecessary use of N95s.
But I think it's also being collaborative. I mean, today I went into the room to echo the patient, so I changed the FiO2, and then the nurse handed me the NG tube, and I put in the NG tube, so that saved 2 trips from 2 other people. And we've all been kind of working collaboratively like that.
For sure. As a cardiac surgeon, I put in a lot more NG tubes and done a lot of things that aren't really what I'm used to doing because I happened to be in the room at the time. For sure, a good point.
Yeah, I think these are very critical comments about a team approach with regard to this, while making sure we truly save the workforce. I love some of the additional ideas that Dr. Coimbra just also added about how do we really use any strategy, and it's a combination of strategies, to minimize the use of PPEs, because we're not in the same position as some other places as they are. And this is making significant issue in all the hospitals that we're at. And so these are very important discussions with regard to this. Antonio, how much time do we have? What's you want to make a conclusion?
I think we go 5-10 more minutes. We have Dr. Lena and Dr. Ali Jafarian. Maybe you can ask them some questions on their experience also, please.
Great. Any experience if Dr. Farhani from Iran can give with regard to their situation? I'm not sure if is he on.
Can you hear me?
Yes, we could hear you. Welcome.
Okay. Thank you very much for this very good and informative webinar that we have today. I just point a few experiences that we got here in Iran. About the PPE, we have the same problem with at the beginning of the surge, because you may not have enough access to all of those stuffs like guns and N95 and surgical masks and everything else. What we did in our hospital and in many other hospitals was a WHO protocol for the PPE, and that was, you know, not quite successful at the beginning because we lacked something at some points. But after the first week, I think everybody could cope with that, and fortunately, we did have enough PPE for the staff. Because I totally agree that keeping the health of our staff is the major point for the people, not just for the staff. And the other thing is that the experiences in the ICU cases for NIV was very good, and all of our intensivists are now trying to put the patient on NIV soon, not to intubate them, because the outcome with intubation was as not good as that was before. And the other thing is that we had in the first report that we are now publishing, fortunately in a few days, just 40% of our inpatients were COVID PCR positive, and the other 60% were just positive on CT scan and clinical area. Everything was like a COVID, but the PCR was negative at the beginning. So I don't know how much is the same thing seen by other colleagues in other countries, but the CT scan was much more accurate than the PCR. And the PCR positive reflected the high viral load in the patients. And what we concluded is that the PCR positive patients had a higher mortality rate. In our hospital, their mortality was like 16% of the total number of the patient admitted, but the mortality was around 10% when we counted all of the patients. I don't want to take a lot of time, and I cut here to listen the comments from the others. Thank you.
Thank you very much. So I want you to have your experience present next week about how you manage patients in Iran, please. I have a quick question, Dr. Hayato. Dr. Hayato is a surgeon. We have a lot of oncologists in this conference, a lot of surgeon oncologists also. So any special device when you have the oncologic patients on chemotherapy or just after surgery, pre-surgery? So any special should be more aggressive or with like management this patient, early intubation, early. So any recommendation, Dr. Hayato, from expertise to manage oncologic patients?
So this is our main concerns, and because we are we have a lot of oncology patients. We just, in the meanwhile, we have this webinar. I just received the protocol by email for oncologic patients, but I didn't read it yet. Actually, the only surgery we are doing at the moment, just very few colorectal cases and just some breast surgery. Because the main issue, we cannot be aggressive at the moment because all of our best anesthesiologists and intensivists are engaged and committed with the COVID. And that's why the surgical oncology activity is reduced by more than 90%. But I think in next webinar, in one of the next webinar, we might discuss this. We are just establishing a protocol.
Okay, yeah, there's a lot of oncologists asking that. I have a friend in Brazil, Dr. Clarissa Matias, they ask, so the patients cannot wait. They need to be on the chemotherapy, they need surgery, so that's their life that's in the line also, right? Yeah.
We were selected as a hospital. We have been selected as a hub center for two diseases. One was stroke, and this is running pretty well. And the other hub was a surgical oncology. But we have been so overcommitted with COVID that we were supposed to accept patients from other hospital, oncology patient, but at the end we couldn't operate on the patient that were on our own waiting list. So we failed at the moment.
Okay, Dr. Abutanos, any other comment for any of the panelists, please? Dr. Abutanos, anybody else wants to talk? Dr.
Sorry, I was muted.
Yeah.
Sorry, I was muted. I'm not sure if Dr. Napolitano was able to come on or not. Probably
she was here for
okay.
She was for a while. Yeah.
Okay. No, I was just commenting on the especially the role of a lot of the tertiary centers, and this last comment by Maru was very important because we're having a lot of patients being transferred to our centers, and we may not be able to take care of them as we're dealing with our own. So that whole idea of working as a system, which I like that was presented earlier on Monday from the panelists. Anybody else has been working as a system instead of an individual hospital trying to solve the crisis? Dr. Bofar.
Yeah, we have a little bit more time to plan. So there's a very careful integrated system between the public and the private hospitals. Particularly the private hospitals are taking or prepared to take significant numbers of the more seriously ill patients. We have a slightly unique situation in that in some of our informal areas, we've got 10 people sharing a room. And if you have moderate symptoms where you'd be sent to home convalescence, we can't always do that. So we have 2 dedicated hospitals for that. And certainly in our hospital, we have specifically multidisciplinary agreed daily meetings so that everyone in the hospital is singing from the same treatment hymn book at the same time. And then that works with the university, the state, the county, and the private. So yes, we have a system.
Very helpful. Going back, there's another question that came up earlier with regard to the use of, this back to an ICU care, with the use of 1 ventilator for 2 patients. We've seen a lot of stuff on that on the online and on the internet, but has anybody had the experience with that? Is that really recommended? Does it work well? about in Iran? Do you guys have any, Dr. Jafarani, do you guys have any experience with that?
Yeah, that was a very popular thing in the internet, and especially in those people who are interested in these issues, but not physicians. I asked from my colleagues in ICU and intensivists, and most of them, said that because you need a specified configuration for each patient, it is usually not useful for the patients. We have not been, forced to do that, and we could afford enough ICU beds in Tehran, of course, and now in all of the country we have enough ICU bed available, and not on the ground experience on that yet.
Okay, thank you very much. I think you are already advancing the time. Another great meeting, great conference. So just to remind everybody, if you want CMEs, so just follow the link and ask for your CMEs. Next week, we're going to continue following focuses on the treatments, strategy for treatments, networks, and I'm going to have a presentation. I'm going to focus what should do with general surgery or emergency surgery during this process, the pandemic response. I'd like again to thank very much for the Pan American Trauma Society, American State Surgical Trauma, International Surgery Committee, the World Coalition for Trauma Care, University of Miami, Virginia University, for making this happen, for supporting this initiative. This meeting is going to be on all these institutions' website, and also a fellow from one of the institutions going to make a summary of the meeting and post also in the websites so everybody can understand and watch again the meeting and have a summarize of the meeting. Dr. Abutanos, your final comments. Thank you very much for joining us and for making this happen, Dr. Abutanos.
Thank you, Dr. Martos. I just want to thank all of our speakers, especially all our panelists, and everyone who has sent questions. Again, to reinforce some of these questions are extremely important, and they will be on the website for the Pan American Trauma Society, so we could get these questions answered. And but just wishing everybody to stay safe. And this conference is incredibly important. Not everybody has all the answers. We are looking for innovative ideas that will help us solve some of the issues that may be important in one area and not important in others. And so we look forward for the meeting next week. And if you have any additional questions or suggestions, please don't hesitate to send this to Dr. Martos or to myself, and we'll be able to coordinate those. Thank you so much.
Thank you all. See you all next week. Thank you.